Hello and welcome to the Parliament of the Republic of Trinidad and Tobago's Cabildo building. On behalf of the committee and staff of the Parliament, I'd like to welcome you to the first Town Hall meeting of the Joint Select Committee on Social Services and Public Administration on Public Healthcare Services. At this time, I'd like to invite members of our committee to introduce themselves, starting with Member Naked.
Good afternoon, everyone. Thanks for coming to this Town Hall meeting. Can everyone hear me now? Yes. It's no wonder that it's so disproportionate, so many more women than we have men on issues of health. By the way, but welcome and thanks for being here.
That's David. Avinash.
Thank you. Thank you, Mr. Chairman. Good afternoon, citizens of Trinidad and Tobago. It's a pleasure to be here to join in this session. First of its kind, so I want to thank our chairman for pulling this meeting together. I am Avinash Singh, and I'm also a member of this committee.
Member Mohit.
Thank you very much, Mr. Chairman. A pleasant good afternoon, members of the committee. I'm Member Mohit. It's a pleasure to have you, fellow citizens and friends here. We do look forward to hearing from each and every one of you.
And we have a guest with us, not officially part of the committee, but we'd like to welcome Dr. Maya Blackman.
Introduced, so I'm Dr. Maya Blackwood, and I'm not officially part of the committee, but I'm here to give my opinion because I think it speaks to what's happening and what we need to do.
Thank you so much. I'm the committee's chairman, Paul Richards. We're really happy to have you here with us. We've planned these town hall meetings to have a closer interface with the people of Trinidad and Tobago on issues that affect them in their daily lives. The rationale for the inquiry and our town hall meetings is as follows. Over the past 3 years, the committee has focused on examining the workings of the education system. During the session of Parliament 2023 to 2024, the committee has turned its attention to an equally important matter, public health care services. Healthcare is a very broad and multifaceted area, so the committee has narrowed it down in terms of its focus to the following 3 areas. 1, combating non-communicable diseases, diabetes, cardiological diseases, and cancer. 2, focusing on the effectiveness of the Chronic Disease Assistance Program. And 3, the standard of service at outpatient clinics. Exactly 2 weeks ago, the committee met with the management team at the Ministry of Health and the regional health authorities to discuss the state's strategies for combating non-communicable diseases. These town hall meetings are being held to provide the public citizens, you the taxpayers, with a platform to directly engage members of Parliament, your representatives, your servants, on some of the critical issues concerning the delivery of public healthcare services in the country. It is an opportunity for you to share your experiences, having approached the public healthcare system and interface with it, and make recommendations for improving the public healthcare system in Trinidad and Tobago. Although the committee is not empowered to mandate or provide redress or remedy for individuals' complaints, however, we do have the power to hold the Ministry of Health and those who manage the public hospitals, the RHAs, accountable for their performance, their policies, their procedures, their programs, and their initiatives. So let me just go through what the committee is and is not for clarity, because some things we are, some things we are not. I know many of you attending today may think there's no difference between Parliament, Cabinet, and even the courts. But as we start these public consultations, it is important that I underscore that these are different arms of state and perform separate and specific roles and functions. We are one of 14 committees of Parliament appointed to scrutinize or oversee certain aspects of the work of the government. The committee's work is not directly or directed or dictated by any political party or any political agenda. The mandate of this committee includes investigating and reporting on all matters relating to the management, activities, administration, and operations of various state bodies with a focus on education, health, gender, tourism, public administration, labor, culture, community development, and other social services. Quite a large number of areas that affect you in one way or another in your everyday lives. Before we start, permit me to acknowledge the presence of representatives of some of the stakeholder organizations who've accepted the committee's invitation to attend. And these include the Trinidad and Tobago Medical Association, Trinidad Tobago Registered Nursing Association, Trinidad and Tobago's Association of Retired Persons, and a country representative of the United Nations Children Fund, UNICEF. At this time, once again, let me take the opportunity to welcome you and thank you for taking the time to be with us today. And I'd like to now pass you on to Dr. Maya Blackman, a member of the Medical Association, who volunteered to assist the committee as a subject matter expert. Dr. Blackman will give her perspective on the level of non-communicable diseases in this country. Dr. Blackman.
Thank you. So I was asked to give an overview on NCDs, and I hope that you get a real picture through my words. The statistics we hear related to non-communicable diseases are startling. We get that. Diabetes, cardiovascular disease, and cancer is what kills us now after we've evolved past the time that starvaceous and infectious disease wiped us out at a pretty early age. Improvements in medical care and other infrastructures mean that, yes, we get older, but increased obesity and the secondary complications that come from it means that we can't enjoy that old age. This committee held a public meeting with the leadership of the Ministry of Health and the regional health authorities on November 15th, where many aspects of what could be managed better from an outside-in perspective were considered. Things like definitely improving long wait lists for services, and decreasing congestion in emergency departments in hospitals. But the way I wish we could improve those things would be less people needing access to them. But I am an eternal optimist. I've been told this many times. Perhaps it comes from seeing babies die days before they should be delivered, to diabetic mothers because the babies are huge, bigger than they're supposed to be. Diabetes is uncontrolled. And this is in patients, women in their early 20s, mothers and fathers literally destroyed psychologically because of that loss. The healing from it is theoretical at best. Maybe it's from asking patients in the prime of their lives, from being asked to pick between a rotten limb and your life, and watching them replay the choices that they could have made, and their faces are tearful and literally full of regret. Or maybe it's from seeing somebody my age, somebody I would consider young-ish, having a stroke and being unable to function fully, often dead within a year, and their families left to struggle in that grief. I mean, struggle financially, struggle emotionally, struggle every ully you can think of. And sometimes more unfortunate is seeing older patients, those people who have worked their entire adult lives, robbed of the ability to enjoy their golden years because they are bedbound, forced to defecate on themselves until somebody can help them coming home from work hours later. I've heard it described as something worse than death, and I can't even think of that. But we can prevent it. You can prevent it. Each of us can do that. Collectively, there is so much effort being put into supporting us in these lifestyle changes, but we still have to do it. We have, to an extent, failed ourselves by not allocating adequate value to our own life and wanting what is easier instead of what's better. The JCS meeting previously asked a really difficult question. They asked, what is the annual cost of non-communicable disease? The answer is that it costs us lives. And one life that could have been saved and it was lost is too expensive. Because by definition, a life is priceless. How do you buy a life and how much does that cost? The JCS looks at the response to the prevalence of these NCDs and aims to get all those organizations and ministries and everything to work together. But that's the outside-in approach. Inside out starts with each one of us, not just the people here, literally every single person. And the improvements that we seek, that we all seek, starts with trust. And trust is built on communication and competence. We are at an individual level responsible for the health-seeking behaviors that our country needs. And I say our, don't mind the accent, we from here. We need that for ourselves. Our children need it from us so that we can teach them. We make reference to the children will lead us, but they do what we do. We are presently not wellness promoting. We are instead very much illness managing and barely managing at that. But like I said, we can change it. And again, the changes we see start with trust. And confidence and competence that builds that. Confidence in ourselves, competence in knowing what is healthy and what's not. And to be fair, that's kind of easy. Every single person here knows that we need to move more, eat less. But we will wait in a fast food line for half an hour instead of cooking something. Same cost, same time, more effort. Because we don't think we're worth it, I guess. I think we are. I wish you thought so too. And what to eat is easy. The behavioral science behind why we pick something full of calories, fat, and salt when we know that it inches us closer to death, much more complicated. But like anything else, it gets easier if we practice it. If we all work on prevention strategies and encourage those around us to make healthier choices like we know we should. Coming in, I was encouraging one nice police officers to not drink a Cokes, right? Things like more water, less sweet drink. And juices often having just as much sugar, so let's try to avoid that as much as possible. More fruits and vegetables because they're lower in calories, lots of antioxidants, and generally encourage weight loss. But also understand when you're eating a bunch of fruits that if something tastes sweet, it's because there's a lot of sugar in it. And a bucket full of mangoes is not a serving. I'm not saying that sugar is evil, but what we need to do is provide the calories our body needs, not more than that. And also things like protein keeps you full. So make sure that you have a lean protein source in every meal. Chicken, fish, not cooked in oil. So not KFC. I think we have one of the most popular branches in the world here. That's not something to be proud of, but we say it rather proudly. We need to reduce our salt intake. Trinis can make food taste so good, so easy. Shadow benny, garlic, onion. Those add flavor without fat. It's not that we don't know what to do. And then we need to reduce our fat intake consciously. We need to be choosy and not cheesy. We add cheese to everything, right? And yeah, they're good fats. But even good fats are still fats. And they have a lot of calories unnecessarily. So an entire zaboka is probably too much, right? Reduce your alcohol intake. Ideally, I would prefer that your only alcohol was rubbing alcohol for cleaning instead of drinking. But like I said, I'm an eternal optimist. And please, stop smoking. In driving here, I saw at least 10 people just walking and smoking cigarettes. And we normalize it for kids because they see it. If you stop smoking, just because it increases the likelihood of literally every cancer I can think of, and when you're lying in a hospital bed missing whatever parts of your body they had to cut off to try to save your life, you might not really think that life is worth saving anymore. and I promise you, you'll regret every single cigarette you had. I think you're worth that effort because the reward is worth it. A better quality of life where seeing your doctor is making sure everything is okay instead of trying to figure out how we manage what's going wrong now. Thank you.
Thank you very much, Dr. Blackman, for that health overview. As we proceed, let me just give you some guidance as to how we will proceed this afternoon. To you, the participants, if you wish to ask a question or make a contribution, you simply raise your hand and the mic will be brought to you. When you receive the mic, you may stand right in front of your seat. You can ask a question or make your contribution. Please keep your contributions respectful. Avoid insulting and or obscene language. And as short and precise to allow as many persons as possible the opportunity to share their experiences. I need to stress that Dr. Blackman is not here to give health advice or diagnose your illnesses or field your questions on your personal health issues. She's here as our guest to give the overview. Neither are we here to answer questions about the public healthcare systems. We are here to get your experiences so that we can make recommendations, and no doubt the policymakers and the stakeholders in the healthcare system will be hearing this and will get our recommendations in our report. So we are the conduit through which you can speak about your experiences in the healthcare system in Trinidad and Tobago. We can't answer the questions about the healthcare system. We can ask you questions that will prompt answers about your experiences. And we've decided on some main areas that we will be focusing on step by step. And they include the management of the healthcare system and your experiences with that, the screening and clinical management, the access to treatment specifically related to diabetes, the access to treatment specifically related to cancer, the access to treatment related to high blood pressure, access to medication separately, prevention protocols, and public awareness initiatives of the Ministry of Health. So those are the broad areas that we're going to peruse step by step and ask you questions to prompt answers in your experiences so that we can get your experiences to put into our report and factor into the recommendations to make the kinds of changes you want to see in the healthcare system in Trinidad and Tobago. Fair enough? Everybody on the same page? All right. So just as an overview, the inquiry into Trinidad and Tobago's response to the prevalence of non-communicable diseases with specific focus on, again, diabetes, cardiovascular diseases, and cancer. Objective 1, to examine the efforts of the state to counteract the effects of specific non-communicable diseases in the population, again, diabetes, heart disease, and cancer. 2, to examine the efforts of civil society to counteract the effects of specific non-communicable diseases within the population, diabetes, heart disease, and cancer. That's why we have some stakeholder groups with us today. And 3, to determine the main policy changes, actions, and interventions that are or may be necessary to effectively respond to the increase in non-communicable diseases in Trinidad and Tobago. So with that said, we get into it. Once again, if you have a comment or a question based on any of our panelists and the areas we're covering, just raise your hand. And your hand is up already. Okay.
Good evening, ladies and gentlemen. I want to make a contribution with regards to NCDs, specifically how I believe the country as a whole is addressing this issue of NCDs. But I just want to get some context first before I drive my point home. Now, in 2016, the Minister of Health, he spoke about the need of taking personal responsibility to bring about healthier lifestyles. And then also in the recent diabetes symposium, about which I believe was a week or 2 weeks ago, he asked the question why people are not willing to make the necessary changes to manage or reduce their risk of NCDs. In the same vein, when one looks at the TT Moves program, which is the flagship program of the Ministry of Health, when one takes a deep dive into that program, it places the onus on the individual to drink more water, eat more fruits and vegetables, move every day. But I am here to say that placing the onus on one sense of personal responsibility, especially when it comes to addressing a big problem like NCDs, has not worked and will never work. So I believe that the direction which we as a country should go should be different. And this is why. I reference the words of Marion Nessel, who is a former senior nutrition policy advisor in the Department of Health and Human Services in the US, and was also the editor of the Surgeon General's report on nutrition and health. She is quoted in an interview as saying, "You can tell people that large portions have more calories, but they will still eat when given a large portion." She said, education isn't enough. You have to change the environment to make the healthy choices the easy choices. You have to change the environment to make the healthy choices the easy choices. So, we should ask ourselves, are the healthy choices the easy choices in Trinidad and Tobago? So, just to answer that question, a bit more context. There were regions in the world known as the blue zones, where people lived to 80s, 90s, 100s in much more, well, for want of a better word, quantity than any other region in the world. And they're not clinging to life as in like they on a bed. They're doing things like people in their 40s and 50s. Gardening, running, and so forth. And the guy who studied these blue zones, what he said was a common theme in all these blue zones was this. What sets them apart is that the environment encourages them to live healthy, as it guides them to live healthy. They don't have to think about it. All they have to do is live their life, and their environment guides them towards being healthy. In other words, they don't have to fight against their environment in order to become healthy. The environment does it for them. So,
I'm going to ask you to start a wrap up, please.
All right. Okay. Well, essentially, what it is that in order for us to change our environment, there are two things which we need to do. We need to make, especially our dietary environment, we need to make the healthy food more accessible and more affordable. And the unhealthy food, we need to make that less affordable and less accessible. And the thing about it is that the reason why we have these NCDs problem is because we live in an environment where the unhealthy choices are the easy choices. Just go down Brian from that, go in any grocery, go as in San Fernando, go down by the cross. The unhealthy choices are the easy choices. So, in other words, we as a country, we need to look at not just managing disease, but we really need to look at changing our environment so that the healthy choices are the easy choices.
Thank you so much. Thank you. And just a note, if you care to share your name, not your full name, we'd appreciate it to get some context, all right? And as I said before, we're going to go through the broad areas in which those issues will come up that you can make comments on. So we start with Member Mohit and the management in the healthcare system. Member Mohit.
Thank you, Chairman. Good afternoon again, everyone. In terms of management, when you speak management of the healthcare system, of course, you know you are speaking of the regional health authority models. You are also speaking of the relevance and impact of policies developed by the Ministry of Health. So in terms of guidance for questioning, I would ask, are you satisfied with the current management of the public healthcare system of Trinidad and Tobago? Any one of you who may have contributions relating to such?
Hi.
Microphone, please.
Hi, afternoon. Just giving you a little rundown of my experience Friday when I went to the Port of Spain General Hospital. I arrived there at 4:45. There were at least 50 elderly people in front of me, and I did not get to see the doctor until 11:15.
PM?
Yes. a.m.
Oh, AM, okay, 4:45
Oh, I
AM.
left the hospital at 3:30 p.m. The healthcare system now, I don't consider myself elderly in no way, but I felt it for the elderly people. Now I use the public healthcare because I love the testing. You can get testing for free, and I applaud that because we don't appreciate the healthcare system that we have in Trinidad and Tobago, where we can have access to certain, like X-rays, blood sugars, you name it, testing, etc. So when I got there, obviously, now something needs to be done with the nurses as well, because honestly speaking, they're rude to the patients, right? And these are elderly people, and they're asking questions because there are no young ones with them. So they're asking questions about, where do I go, but to be yelled at or spoken down in a derogatory manner, which is not nice. And there was a particular nurse that was not well that day, I'm assuming, and she was very, very aggressive towards the elderly. And I mean, when I went to the doctor, I couldn't even go to the doctor with my issue because I had to fight to actually see the doctor, because if I didn't take a picture of my card, it would have gotten misplaced. They couldn't find my file. So you could imagine their situation, and something needs to be done about that. The other issue is one pharmacy. They had to take someone from the pharmacy because she was more customer service oriented and she had empathy towards the elderly people to actually go across, come outside, talk to the elderly, say just now everybody will be seen about, don't worry about it, that kind of thing. If it wasn't for her, I would not have seen the doctor probably until after 2, because she took it upon herself to actually go into the filing room to look for my file. So you could imagine now, previously when I went to the doctor, she said, there's loose files in here. There's lose your card in here. Well, I mean, she's not supposed to say that, but she's speaking the truth. So something needs to be done about the wait time, 1. 2, the wait time for the pharmacy. I waited 2.5 hours for medication. And I'm young, and I have a back problem. So you could imagine those elderly people there waiting. Sometimes they come there at 6 o'clock, and they don't get through until 9 o'clock, 10 o'clock. There was a gentleman there who reached there from 4:30 in the morning. He did not get seen until 9:45. And he just went to let the person know, here what, I was first. Everybody knew he was first. They put his card all the way down to the bottom. Why are we treating the elderly people like that? I mean, I'm not going to give you my experience with the doctor, because that... When I went to the doctor, I know you all study hard, and I know, I applaud that. But you all start to need to listen to the patients. She was not listening to me at all. And as I said, I didn't come there to fight, because I had to be on my best behavior so that I could get seen about, because that is what you have to do when you go into public health. Good morning, good afternoon, thank you, yes, really patronize them and be on your P's and Q's and try not to aggravate the nurse or the doctor. So when I went to this particular, she's a very young doctor, and I was explaining to her, now I'm going through menopause. And I realized menopause is not a thing in Trinidad and Tobago. It's not a thing for doctors. It's not a thing for nurses. They bypass that, they ignore it, they push it under the table. So I had a hysterectomy. She told me, no, you're not in menopause. You've gone through menopause already. So I'm telling her, well, I'm giving her the symptoms of menopause. And she said, well, you know what? You need to see a psychiatrist because you are depressed. But no, I am just going through menopause. I'm having the symptoms of menopause. Treat me for the symptoms of menopause, and I will get through with the nutrition and everything. But you want to send me to a psychiatrist. You understand? And a lot of women are suffering from menopause, and we are ignoring. And if we go to the root, she even diagnosed me with cancer. She said, I had a hysterectomy, so she said, oh, so that the cancer would not come back. But I didn't know I had cancer. I did not know my hysterectomy was because of cancer. But you're not listening and you're not reading. I think that is the number one problem that we are having. They're not listening to the patients.
Thank you so much.
Thank you.
We'll take one more before we go back to Mohit.
Oh, sorry.
Thank you for sharing this.
Oh, it was her. Oh, sorry.
Thank you. Good evening, everybody. Natasha Nunez is my name. And I just kind of wanted to follow up to what Jillian said. Now, women over age 40, like myself and many women in this room, make up 20% of the population. Every one of them who has a period will go through menopause, which is a natural transition that marks the end of the reproductive cycle. While everyone experiences the transition differently, no one deserves to suffer as a result of the misdiagnosis, positive information, or dismissal of their symptoms, as Jillian just described. I and Jillian represent the Menopause Empowerment Network of Trinidad and Tobago, MENOTT, which is a newly registered NGO dedicated to education, research, and advocacy around menopause. While the organization is young, we have set up a private Facebook group which now boasts of 770 members. Since we started this group in March of this year, we have noted the significant lack of information among this population of citizens about menopause, about the symptoms and the treatment options. And we are here today to articulate our own concerns as we are going through the transition as well as for those of our members who, for the most part, are not prepared for the onset of menopause, whether because of their age, the symptoms, or whether they go through an induction or induced into menopause by surgery. They are not treated with respect and dignity when they present at hospitals and health centers with menopause symptoms. They are not given information nor treatment options to alleviate the symptoms, which can be debilitating in many instances. They are not aware of the increased risk that menopausal women face for cardiovascular disease, diabetes, and other chronic illnesses like cancer and stroke when they enter menopause. They are prescribed medication for each symptom, as Jillian just described. The doctor wanted to send her for counseling and give her medication for depression, which is a symptom of menopause. So they are prescribed medication for each symptom, not taking into account the female reproductive system looks different for each person, including those who are going through a gender transition. And they are unable to access different types of hormone replacement therapy. Currently, there are many types: oral, patches, creams.
If you could kind of bring it in terms of how you'd like the management of the system to change to accommodate for that, so we stay on track, please.
Get into that. So, we would like for public healthcare professionals and the system itself to recognize menopause and women's health concerns in general with the care and understanding it deserves. While it's not a disease, it is a significant transition in a woman's life that should be embraced rather than feared. And women at this age, who are some of the most productive citizens in this country, should be enabled to live happy, healthy lives as we age.
Thank you. I saw a hand up in the back, and once again, we're talking about the management of the healthcare system at this point. If you have a comment on the management structure and the management systems in the healthcare sector, we focus on that in this segment.
Hi, good afternoon. Individuals will recognize me. I came with a walking stick. I was in an accident 19 years ago, and I'm from San Fernando. I'm not familiar with Port of Spain Hospital. It sounds as weary as San Fernando, I would compare it to, in that I have been in San Fernando 19 years since, and my first file, which was thick as an encyclopedia, got lost. My second file also got lost. And with our country following the new age of technology, why isn't the system computerized? Instead of having somebody to go in a file system looking for a file. Added to which, with the accident I was in, I knocked my head, and according to doctors, I was diagnosed with glaucoma. We have to take drops and all that for the eyes. I am presently a teacher, and I can't afford to always be leaving to go to the hospital to pick up these drops. So I have, like, my husband will go for me, or I have a relative going with my card. And sometimes it's valid for 6 months, and I need to renew it. But to go and see a doctor, the ENT in San Fernando Hospital, means taking a day. It's very difficult to take a day just to go and get a form filled out to get eye drops. You're not getting any medical. It's something they diagnosed me with. You don't have to go through any system. It's from an accident. So somebody told me I could have gone and, a doctor would have filled it out and, it wouldn't take long. So I took time off from work, went down in the morning, went down like around 8 o'clock. They took me to the ENT. They said, don't worry, somebody coming out. 12 o'clock, I'm still waiting. Somebody coming out. So I went in to see the doctor. He looked at me, stamping out less than 2 minutes. I waited 3 to 4 hours for less than 2 minutes. So I'm just suggesting the patients who don't need to actually see the doctor to go through a full checkup and all that. If through the medical file could prove, yes, this person needs the medication from the pharmacy, can't it be a quicker 10-minute process other than 5 hours? Just a suggestion.
Thank you so much. Member Mohit.
Before I hand over to Mr. Chairman to continue, I just want to let you all know that we appreciate your comments thus far, and it will be taken into consideration by the committee going forward in terms of our recommendations. But as women, we do appreciate your contributions here today.
Before we move on, does anyone have a comment on whether you're satisfied with the present regional health authority model, like the RHAs, the way they are central to particular districts in the country, and how you think they're managing the healthcare sector or healthcare services delivery, district by district?
A pleasant afternoon all. Edie Stewart from the Nurses Association. So my personal point of view is that we have seen a couple of the RHAs working reasonably well, and those are the smaller RHAs, TRHA, ERHA, but the larger RHAs appear to have been struggling a bit to really deliver quality care based on their population size, whatnot. But in any event, the specific question, we are asking a question. It's a little unfair because the regional health model was framed from the UK model. That's basically where they got it from. And within the UK, they had other systems to assist in delivering care and not totally focus just on the RHAs. So for instance, and just to point out some of the issues that my colleague raised there earlier to the front with some of the shortcomings, we still do not have health sector accreditation. That was supposed to be present. So we could have treated with institutions that are not up to scratch. So currently there's no institution in Trinidad and Tobago where it will evaluate, public or private, evaluate those healthcare institutions if they are meeting certain standards to receive reports and complaints and deal independently with those organizations. So, and public or private healthcare institution could perform how badly, nothing would happen to them. Secondly, if we had quality councils, that's another aspect of the whole health sector reform. The RHA model, the RHAs themselves is just one aspect in the whole continuum. So out of the 7 areas of health sector reform, we only implemented one, which is to create 5 COs, 5 RHAs, 5 human resource departments, 5 of everything, and not really increasing. There's so much to say, but I'll be very brief. In terms of the regulatory bodies have not been functioning to treat with some of the issues brought up by my colleague there. Continuous training. staff being ill-disciplined. If you would, well, it's very difficult for us to begin to even find the information of healthcare professionals who would have been disciplined by their regulatory bodies. It's not published as you would get in other jurisdictions. In Trinidad and Tobago, you have to know someone to find out if a particular doctor or dentist or nurse was disciplined. And from the information we have in nursing, in the history of our regulatory body, we had probably 2 persons ever being disciplined by our council. And the Medical Association is no different. Dental Council is no different. So we are, and those persons, the doctors, the dentists, all of them are professions in their own right. And it is not only up to the institution to discipline them, but it's also up to the regulatory body to discipline them. So if we don't have those additional structures in place, the entire system will end up falling down. And I will close off for now. I hope I get another opportunity to deal with the aspect of NCDs. In fact, I'll leave that for another time.
Thank you, Mr. Stewart. Member Naked.
Good afternoon again. Has anyone encountered challenges?
Your microphone.
Oh, sorry. Has anyone encountered challenges when it comes to accessing medical screening when they go to any of these public health institutions?
There's 2 hands, the lady in the blue in front first, and then we'll deal with the person in the back.
Thanks. Good day, everyone. My name is Avion Drayton Bailey, also from Trinidad and Tobago National Nursing Association. My personal experience, I'm a nurse manager. I worked just up to last month in the RHAs. And one of my areas that I managed was an outpatient clinic, of which, as I said, I'm a patient. And I have been waiting for an echo for nearly 2 years, right? And you would think that even being in the system, that I would have been able to get through. And that has not proven to be the point. And
is there a particular reason why they have you waiting? Or is it a scheduling issue?
It's a long waiting period. So I remember, so my process is I was feeling ill. I went to the staff doctor, and she would have directed me to have an ECG, from which she found out that there were some irregularities. She would have referred me to the outpatient cardiology clinic, of which I am in charge. I would have gotten an appointment 1 year later for something that the staff doctor felt was urgent. It would have happened during COVID period. So that was one thing that I felt, well, okay, it's during COVID. And I was telling Mr. Stewart earlier on, so telehealth or telemedicine that they are saying that they have implemented is not real telehealth or telemedicine. As a nurse who thinks that I know a lot, the doctor would have called me and asked me a question about the echo, and I told him, yes, I'm waiting to be called for the appointment. And they said, oh, well, see if you could get through to ask somebody, nurse, you're working here. And I said, well, it don't work, so because it's a long list, and I think my appointment might be for 2024, if not 2025.
And this is for a heart complaint?
For a heart complaint.
And a 2-year wait? A
2-year wait. And the thing is, I did not even realize that that was the telehealth discussion. I thought the doctor just saw it, because the doctor who saw me the day kept my file and said that I would go through to see if I could push for you to get the echo. So even though the phone call was like a year later, in my mind, they just remember that they had it and they called me. I didn't realize that that was my appointment. So I told the head nurse, because I'm her manager, I was like, they called me the other day asking about the echo and thing. I said, I guess they'll call me just now for me to come to clinic. She said, no, that was a clinic. I said, my clinic? I said, no, they just called and asked me about the echo. I'm still waiting. It's the end of 2023. I have not yet been called for the appointment for the echo, which would have been in 2021. And
I am, as you said, I'm still young. I could still strong. I could move about. Can you imagine an older person waiting to get an appointment for an echo in order to continue to even see a doctor to know what else to do? So even if I had a heart condition, 2 years has passed, it's getting worse, so if it's anything, I'm yet to have an appointment, and who's to say if when I get that echo appointment, if now the clinic appointment will be a next year later or 2 years later. So that's my contribution.
Thank you. There's a hand up in the back. Indeed.
Good evening, or good afternoon, everybody. My name is Janice Chase. I am a retired worker. Hi. Oh yeah, that's you. And I have been waiting to get to the eye clinic because I am diabetic. At least I was in the one at Mount Hope, and they transferred me to Santa Cruz because I live Santa Cruz. And Santa Cruz doesn't have an eye clinic. And I'm still waiting to go back to Mount Hope. And I'm still waiting.
How long have you been waiting?
Good question. About a year and a half to 2 years. I went to my private person who I get my glasses from. But when he did my blood sugar, it was 200 and something, so he said he couldn't do anything for me because my blood sugar was 2 something. Now, I am on insulin from the time I've been diagnosed, and yet still, if I go to the clinic, I cannot get a prescription because I'm going out of my clinic time. So it's really tough, trying to get your life lived because you're not doing what you're supposed to be doing. And one of my problems was I drank a Coca-Cola almost every day. So I heard doctors speak about that. So I think that's why I became diabetic, because that was the oldest thing I drank. Coca-Cola, water, and tea. I still drink plenty tea but Coca-Cola and thing I cut out. So I drink water and tea now. Those are my 2 drinks. I do ever drink orange juice and sorrel, and water and tea is what I drink.
2 people with their hands up. Right in front of you. Oh, sorry. Go ahead.
Hello, I'm Melody, and I'm a trained sonographer, and I've wanted to work in the public service for a while now. Sent a couple of applications, and I know that there are vacancies. I also looked into visiting the Deo Martin Health Center for volunteering opportunities, and there was a lovely lady there. She's retired. She works 2 days a week, and there are 3 days where nobody's doing ultrasound. And I'm a young person. The government has paid my full tuition for me to do this, and nobody is calling me back, and there are lots of people who are in need of ultrasound. So I'm asking if you can look into the requirements for being more proactive and vigilant with returning correspondent with future applicants, and at least allowing them a chance to be interviewed, a practical interview preferably, so you can see their competence and what they're able to do. Also, have a probationary period, 3 months, 6 months, to prove themselves that they can actually work under the pressure and in the environment. So that's what I had to say.
Thank you so much. There's a lady in the black and a gentleman in the white shirt. And then we go back to Member Naked.
Hi, good afternoon. My name is Melissa Mohammed. I'm from the Diabetes Association in Trinidad and Tobago. So in reference to the eye screening and foot screening part, I can safely say that yes, patients do have those problems. One, we have tried to actually find out why isn't it mandatory at their clinical visits that they get eye screening and foot screening at every visit, right? With our association, foot screening. No, well, that's what I'm saying. It should be part of their clinical process at each clinical visit. Their clinical visit is every 6 months, right? So they should be able to get a screening for both eyes and foot. I operate out of the Arima Health Facility, right? Under our association, we do free eye screening for persons with diabetes every month. So far for Arima, we would have done over 240 persons. However, that screening is done with Trinidad and Tobago Eye Hospital and not the public hospital. That's on that's on the highway at the corner of Pachi, right? And that is just for Arima. We go throughout the country, right? And it's directed for persons with diabetes. So sometimes for the year, we would actually see close to about 2,000 persons, right? In terms of the surgeries that comes out from this, Trinidad Eye Hospital has been able to do 2 sets of surgeries for the year. In July, we do the gift of sight, where 37 persons get free diabetes eye surgery. And then in December, again, we do another set.
And you're talking specifically about the Diabetes Association initiating this?
Yes.
Okay.
Right? Because it's not available. I've had persons who have come through my office and done the screening and are awaiting appointments at the Arima Hospital with their referrals to even get an appointment. Up to this morning, I had a person call me because they went back to eye hospital because his eyes is getting bad.
And what is your interface with the Ministry of Health, given that you're screening people and I guess giving them medical information that they can go to the RHAs with?
Not much. I just advise patients and them where to go.
Okay,
right?
Thank you.
Because I would actually, so we advise them to go through the system. Well, I've actually gone through the system to see how it is because I have heard where persons say, yes, they get a bad service from the doctors, yes, they get late appointments. So I've actually tried it where you go through emergency, you get a number, you go to the GP, and it's serious. You get a number, you go to the GP gives you a referral to the clinic. When you go to the clinic, they give you had to wait 3 months to actually get an appointment. Well, and this is it. So somebody is diagnosed with diabetes or any type of illness, and then they're waiting 3 to 4 months for an appointment. They go back home with no type of knowledge, no type of just sitting down there. We talk about eating healthy and exercising and all that. What we don't talk about is that mental part of it, because you're sending back somebody home diagnosed with something and they're not sure. They're going back home, they're studying what's going to happen to me. From the time somebody hears they have diabetes, the first thing comes to my mind, oh my God, I'm going to lose my foot. Any person that's diagnosed, we forget about that emotional and that mental part of it. And that is what takes a toll on the late appointments.
Thank you. Can we get the gentleman in the white and then back to Member Naked, please?
Good afternoon, everyone. Talking about the experience that my father encountered. He lives in Tobago and he has a heart condition. So to really get a doctor that really is permanent there is impossible. I hear that the doctor has to come from Trinidad up to Tobago. And he hasn't seen the doctor over the COVID period. That COVID, he was diagnosed. He used to go to the clinic before to see the doctor up in Scarborough. And of course, visiting the doctor was far. Getting appointments was far. So anytime he get one, he got it. But for the COVID period, he didn't get any. And since then, after the COVID, it's difficult to really get an appointment for my father to see a doctor for that particular ailment that he has, which is dealing with his heart. Right now, thank the Lord, he has to go private, which is a costly figure to see a doctor to deal with your heart. But he really, really and truly, he should be able to get access.
So you're suggesting it has been his experience, your father, that
Correct.
the Tobago Division of Health does not have a health specialist, a cardiologist.
In that area, yes, in Tobago. That
And
is
there's none in the whole of Tobago that he can access?
Well, at the public health center, if, for example, well, right now he's going private. He has to go and see a private doctor, but he used to be in the clinic, and now he's not in the clinic. I don't even think they could find his file, but that is the experience.
Thank you. I think there was a lady in front of there, or two people there.
Hi, pleasant good afternoon, everyone. My name is Kelda Cornwell from TTNNA. I'm also a nurse. I'm attached to the Diego Martin Health Center and also the MIS department. Speaking of management, in terms of equipment, now I am the one responsible for doing ECGs at the Diego Martin Health Centers. However, we had 3 machines. One broke down. We wrote. They said, you all have 2 more, so okay, if the one is broken down. 2 more, 1 broke down, 1 more. We'll come and try to see what we could do, and then the 1 broke down, so there's none. So when we used to facilitate persons every Thursday afternoon between the hours of 1 to 3, doing ECGs, or sometime once I am free in between the clinics that I don't have another clinic to do, I will volunteer my service to do out of appointments because I feel the pain of the public not having to have these services. Now the health center has no ECG machines, none whatsoever, that is presently working. In reference to bloods, we have HB1Cs and CBCs. There were some machines that were specially attached to the Diego Martin Health Center. However, some of those machines are down at presently, so the bloods can't be done. And if you send for bloods at Port of Spain General, at some point in time there was an issue where getting the bloods done, that was another story. And you had to tell patients to go on the outside to see if they could get it privately based on the nature of their illness, and you want to know what their HB1C is. Because that catchment area, I've worked in other health centers before, but it seems something about that western area, Diego Martin, the HB1C is always 15.1, 16.1, it's always high down in that region. So I don't know what particular diets you're having down in that particular area. The diabetes, the chronic disease where diabetes is concerned is very high in that area. However, my thing is with management is it takes too long to get the equipment, whether it's to be repaired or a new one. You always have to be going around some red tape, run up a hill, go down the bamboo, and it's like, I mean, we're trying to help people here. And when people get frustrated, they abuse the staff. No, I am not in control of fixing the ECG machine. I'm the one, I have the skills to use the machine to get the report done so you can get back to the doctors. I can't fix the machines. So if someone could just, management, and I work for NWRHA, by the way, so I'm just speaking about this one particular region, and there are other issues with other regional health authorities as well.
Thank you, Member Naked. Before we go back, we'll come back to the audience in a short while. We just want to move it along. Thank you.
But first of all, I'd like to empathize completely with the sister here, that being part of the system does matter. Some of you will know as nurses, my mother was matron for the General Hospital for years, and then Mount Hope. And then she needed some screening, and she had to wait also 8 months, and by the time she got it, she was diagnosed with cancer that had spread, and she passed in 3 months. So I empathize completely with the situation, and I hope you get checks very soon. Well, some of you all mentioned it in your experience about the lack of doctors or specialist doctors and so. Have any of you all have any experience with that? Not being able to access a specialist doctor for your particular situation? Or lack of doctors available?
Well, at the Diego Martin Health Center, when I speak about...
Use the mic, please.
Diego Martin is a very large catchment area, and one of the problems we are having is that even if they say they attach 5 doctors to the health centers, they always take at least 2 of the doctors from the institution and send them to other health centers where they are short. Now, to be honest, we have a very large shortage where nurses and doctors are concerned out in the community. And we speak about healthcare, and I believe primary healthcare is the first place where all the preventative measures are at the primary care level. So if we don't have sufficient staff at the primary healthcare level, then we could see all the other issues would be fluctuating over into the hospitals and other places. So prevention, as the old people say, is always better than cure. So if we could have more staff, more equipment throughout all the RHAs, I think we would be in a better space, because we only have one dietitian. How much appointments this one poor dietitian has to be talking Monday to Friday, whole day, and there's only one person, the sonographer. She's a senior person as well. We need young persons to be working in that department. Persons have to wait like about 3 weeks, 4 weeks, 5 weeks. Imagine you come as a pregnant mother and you want to get an appointment for ultrasound. She's going to tell you the next 3 weeks or the next 4 weeks. When the doctor is saying on the line, it has a red, that you need to have it ASAP. But because of the overload, it's too much. And I'm hearing a sister at the back saying she's trained and all of that. Where is it? What's the problem? What is happening? What is going on? We're speaking about management. What is happening where management is concerned and having all these matters dealt with?
In front.
Good afternoon, everyone. Jennifer Rouse. Well, I was in the system. I'm now a happy retiree, but now from a civilian. But while there, no, this is recently. So now as an elder, I mentor across, not by profession, but just those who need and come to me. And there were 3. Finish their doctorate, this is in medicine, finish their internships, and can't be placed. And I am like, something is wrong with the equation. One was home for 2 years, calling every so often. Some others were getting placed who were in their class and didn't even get the grades they got, but they were placed. Okay?
And this is doctors and nurses, or both?
Doctors. There's doctors. And these are young doctors. They're in their 30s. I think maybe one was nearing 39 was the eldest. The one who was 36, she left for England. She got her placement in UK in August. She left. But while waiting, knowing you aced your classes, you did what you had to do. She went to Grenada. I had family there. I said, look, try and see what's happening in CARICOM. She got a placement at the St. George's Hospital. She worked there for, I think, a year and a half. Her other schoolmate, who got the same amount of grades and passes, she had to go to Muna. Nothing, no placement. And they calling her, nothing doing. Eventually, well, she said, oh, she was missing home. She came home. And during that time, she was at a private, one of the I think it was Sinclair Medical, 2 days a week, only in the morning. By the time I look, she's back. And so she would go to the gym. She had to find things to just keep her sanity. So she went to the gym, she did also, and well, she's now in England. So now we have to look at placements. We have to look at where the supply side is and the demand. And this is all falling under management and administration. And I remember when even being in the system, that was one of the key areas. No scholarships are awarded there to do health management and administration. You see that one? Nobody. And even when I did my degree away in public policy, there was a track called evaluation. No student does it. The professor was asking what it is about evaluation that nobody takes it up. Because all these things have to be marketed. These are niche markets that people don't know. So we have brilliant students in Trinidad and Tobago. But they study in either what their parents tell them to study or their friends going and study. There is no master plan. like a macro plan to say, look, these are the areas. This is how Singapore and these people do it. They see all the areas where there are gaps, and then they track the students who have the orientation towards it, and then they bump them up and give them the scholarships to do it and return home.
So the needs analysis drives the student scholarship areas.
Exactly, because we keep talking of the problem, we're not getting at the nitty-gritty of how you make the dots connect and allow our people to be homegrown and serve the public. So that gap could be false because they are there, but they're not getting the placement.
Thank you, Dr. Ross. It's great to see you, by the way.
Thank you.
Let's move on to, are you completed? Member Singh, go ahead, please.
Thank you, Chairman. Switching to diabetes now, Mr. Chairman. This committee is interested in knowing from you, the public, have you all had any challenges in accessing treatment, for example, dialysis? And if so, please share some of your experiences with us. Anyone? Chairman, I would like to share my experience.
Please do.
From my grandmother's perspective. You know, I've listened to some of the concerns of the public, and this thing about losing file. Believe it or not, my grandmother, who is now 83, a couple of years ago, and her list of complications now is too long to name, but diabetes and her kidney failure, you name it, waiting on the system for the government-aided dialysis program. So she started on dialysis on her pension. She would have probably over about a year and a half funding this. Of course, her pension depleted, so family resources had to be used because it's 3 times a week, $900 per session. Just to put some perspective, a plaster when you go to dialysis, for dialysis, the institution, I wouldn't call the name, the institution charges these patients $20 for $1 plaster because you're coming there for this session. So it's $900 for the session, $20 for the plaster. A bottle of water is $5 in case you have a sip. And she's there waiting, and you know, it took her 1 year and a half, and the same reasons her file got misplaced twice, waiting on the system to be placed for dialysis. And it took me, you know, the understanding of what the public really goes through, because me being, I would say being in, not in the health system, but being in the public system, having access to doctors and nurses and the minister and whatnot, you know, we really need to move away from this hard copy, this paperwork system, and move into digitalization where you can go to any health facility in the country and your entire medical records would be at the disposal, you know, of the doctors, the nurses, and the patient. So that experience, I mean, and thank God my grandmother, she's alive. She has been in dialysis for the last 2 years. And thankfully now, only about 3 months ago, she actually got through to the government-aided portion. But if I were to check how much money she spent, that pension that she received as a pensioner simply could not have paid for her, and she would not be alive today to tell that story. And I mean, it's really, you know, disheartening to know what people go through. While I'm grateful, because I personally, Mr. Chairman, believe it or not, I am a user of the public health facility. In 2018, I was the victim of over 300 bee stings. I spent 2 weeks in Mount Hope, and in my growing up, I always turned to the health center system, Shoguna's Health Center, and that is why now when I do go by a doctor and they ask, okay, could you bring your medical file? I mean, that is the hardest thing to get from the public health facility because it's not digitalized. So I just want to, while empathize with you all, I am still a little bit grateful because I have been a user of the public health facility, and I am grateful for some of the tests that some of you all referred to in getting and accessing. But much more needs to be done in terms of our elderly. That is the one that really touches my heart, because to see our elderly who have contributed significant years of their life in practice, some of you all here today, nurses, doctors, the members of the Diabetes Association, and for now, tables turn for you to be on the next side of the table trying to access the facility is very disheartening. So definitely, Mr. Chairman, with your leave, the recommendations from this committee going forward to the policymakers like myself and the administrators, it's very critical that you all, share your experiences so that we can take proper record, proper stock of it when we really go out there and try to make a difference.
And just to share, this is the first of a series of public town hall meetings that we plan to have all over the country. So those of you watching this will be certainly will be coming to an area near you soon. Member Singh.
Chair, so in relation to sticking to diabetes, for members, can you all share with us, have you had any challenges having surgery performed at the medical facilities? And anyone have any experience regarding accessing a surgery at the health facilities? It could be from the nurse's perspective, it could be, yeah.
Good afternoon again. In regards to the patient, because I'm a patient advocate as a nurse, I did the program in the wound care program. So persons who have the diabetic feet, and some of them who, because they live on a hill, they can't come down to the health center as often as possible to get their checks. And there are persons, when they get injured, they take too long that by the time they get to the health center and you refer them, sometimes they have the dry gangrene or the wet ones. And what I've seen in the recent times, because I'm talking very blunt here this afternoon, because it hurts my heart, when the doctors at the health center refer the clients at Fort Spain General Hospital, patients come back to me at the health center saying they have to wait for an appointment. So I'm like, didn't they see the necessity or the great need for amputation or some other debridement or something of the sort? And for the past couple months, I've been seeing these problems reoccurring. I call them the recurring decimals. And it's painstaking to see that we have, as we say, the elderly persons coming back. Some of them, you have to try to assist them because some of them, they can't see properly. They don't have no relatives with them. And boy, oh boy, the list goes on and on. So in terms of the time span again, with these issues, it's a huge problem. We're getting the surgery.
Let me ask a question based on that general idea, and anyone can choose to answer this, because one of the issues that the healthcare system faces is people taking a while to actually go to get a diagnosis and no treatment. So the question is, how much do the experiences and rumors and information from your family members and colleagues about the long wait time impacts your own decision about seeking health care? Does it at all? And anyone can, we want to get your feeling too, because very often we get a sense that, in particular men, women are more likely to seek health care. But I know men, if you know you're going to have to wait 6 hours, 8 hours, you say, you know what, I'll do it next week, and I'll do it next week. How much does that issue affect your decision to seek health care immediately or as soon as possible? But we can, microphone first, thanks.
I'm Cynthia from the TAP Association.
Hold the mic closer, please, Cynthia, thank you.
That question applies to me because my parents were now deceased. When I retired, I had enough time to take them to the health center and so forth. And it was really, really hard, for me. In the first place was my father, right? He was diabetic, half blind, and I would go there early in the morning before 7, had to take a number and wait. Now, I didn't mind waiting because I had the time, but for my father, I find it was very unfortunate, and then I had to go through the similar thing with my mom. So because of that, I hardly go to the health center unless I go in for like a flu vaccination or so. I make the sacrifice to go to a private doctor, where I don't have to wait that long.
Because you can afford to. Fortunately.
Well, I sacrifice doing other things and make sure I have that money, whether it's insurance or whatever, because I find it's really hard, for seniors to go through that.
Yes.
That's my contribution.
The lady in the back, put her hand up first, and then the two ladies in the front, please.
I too, good afternoon again. I too put off going to the health center because it's like about a month now. I keep telling myself, Janice, on a Wednesday, go to the health center. Janice, on a Wednesday. But I just don't go because I have to wait too long. I have to wait. Especially if you don't have an appointment, you just have to wait. That's what the nurses tell you. You didn't have an appointment, so wait. They don't care that you're a retired staff.
But
they
my experience
just
has
don't
been,
care.
even if you have an appointment, you have to wait.
Yeah, even if you have an appointment, you have to wait, yeah? Fellas, if you don't have one, you're waiting longer.
In a reasonable conversation, I don't think people mind waiting a reasonable amount of time. No one expects in a public healthcare situation to get healthcare immediately, but it has to be in a reasonable amount of time. It can be 6-8 hours when you are feeling ill.
They don't care.
Well, I wouldn't say they don't care. Maybe the systems aren't what they're supposed to be. We had two hands up in front here.
Hi, Gillian Trumpet from, I have to say Menotiti. For me, what I do, because I'm going to the healthcare center in Santa Cruz tomorrow. So tonight I'll mentally prepare myself. It is the truth. I have to psych myself up and say, Gillian, you're going to wait and be patient. Because as I said, when I went to the hospital on Friday, I did not expect to wait so long. I expected a wait, yes. But there were people before me that came. People came after me that went in. People came in at 10 o'clock, went in before me. And because as I said, there was an issue with the file. And what I've started doing is I use my cell phone and I take pictures of everything the doctor has not written down, but like my tests. So I have all my tests on my phone as well as the card that they give you because they couldn't find the card. And I showed her the time, which was the time I presented the card. When I took the picture, so you'll have the time when I presented the card to put in the box. So you can't tell me, obviously one of you lost the card. And it states Port of Spain General Hospital on a seat. So that is where I took it. Why we have to go through this? Something needs to be done in terms of, and as I said, the pharmacy. You can't have one pharmacy for the general hospital. I can't wait 2.5 hours just to get some medication. What about the elderly? And that was my main concern because who walking with a stick? Who sleeping on herself? I had to hold up a woman because she was sleeping on herself. And that's not right.
Yes, can we?
Yeah, just to add about my experience with the public healthcare system, I have not been a user previously, but of course, as I age, I'm developing symptoms of menopause, right? So I had nausea and dizziness. I decided to take a day's sick leave and present myself at the Digger Martin Health Center, which was a mixed bag. Very good service, pleasant people, and I think I only decided to go there because my good friend Jillian said, I am always in the hospital and the health center, go, it's free. And I said, okay, I will register the health center because it's right up the road from where I live, it's convenient, it's free. So I go there, get there at 7 o'clock in the morning, and I don't leave until after lunch because I have to register, I have to wait, I have to sign up, wait to see the doctor. And interestingly, when I did see the physician and told her my symptoms, she didn't want to hear anything about menopause, but she prescribed me anti-nausea medication, which I did not take. However, in the conversation that I did have with her, she recommended that I take a supplement, a B12 supplement, which I did, and it worked. So it's a mixed bag in terms of the services that the doctors provide, the conversations you have with them, even though they may not listen. In many cases, they may not listen to the patient. You could pick sense out of nonsense sometimes. I think I was lucky in that regard, that my illness was treated with the suggestion of the physician. But if I had known that I had to wait a whole half day just to hear that you need a B12 supplement, I would not have gone.
Thank you. A lot of hands in the back at the gentleman, and then the lady at his left side. And again, can we try to keep the responses as concise as possible so we get as many responses as possible, please?
Okay. One time I went to the San Fernando General Hospital on the advice of my brother, who is a doctor there, because I had a knee problem which originated from work, and well, the increased workload, which was done in a short period of time, I developed like a serious inflammation in my knee, as in like I couldn't even sit down like this without taking like about 5-10 minutes to do that. So my brother advised me to go to the general hospital to go and well get screened, and then well the relevant sector will take you from there. When I went in and I saw that long snaking line in the triage room, I said, okay. And then when I wait 10 minutes, 15 minutes, 30 minutes, and that triage line was like, it looked like if it was getting larger. I called my wife and I said, no, I'm not dealing with this. I'm walking out and I'm coming home. I'm not dealing with this. This knee will have to be seen about some other time. I am going home because I am not dealing with this. Let me tell you the backstory. She called me, as in like, I called, but I don't think I called. I think I left a voice note. I said that's one. She called me back, begged me to stay. Yeah, even had called my father, my brother, just for me to stay inside there. Because when I saw that triage line, I said, okay, I had to go through all this just to see about inflame me. No. So that was my experience with regards to that. Because the time is long, and when I saw that time, it was, and when I heard about previous instances where my wife, she had to wait like all kind of 8 hours, 10 hours just to get seen about. I was like, no, forget this.
Thank you. Next to you, and then the lady in black, and then Dr. Rouse. Well, next to you. Okay.
Hi, good evening again. I remember some time ago, I had a pain in my stomach, and well, I didn't know what was going on. But from past experiences, I realized to go and wait in the hospital was like ridiculous. So forgive me, because I have a walking stick, I figure I'll take advantage. And I called the ambulance. They came right away, and I got immediate care. Now, I'm not damning the hospital system, because San Fernando General Hospital is very efficient. In that when you go for something, they give you ECG, ultrasound, X-ray, they check everything. They don't have all the machines now, but back then they did. And they check everything thorough, and I was very appreciative of that. I reached there 8 o'clock. I got attention by 9:30, something to 10, which is excellent. Being not waiting 3 hours, it was like an hour or two. I had to spend the night in the hospital. Didn't know what was going on because I didn't get the tests back. But I had gastroenteritis, so it was not that bad. But it was efficient in that, yes, they took thorough practices and they were very efficient in giving me the standards of quality, the attention I needed. But it's just sad. Via the ambulance, it had to happen that way. I'm being real. Because if you had to go in the hospital and wait by accident in emergency, You're not going to take hours for them to even see you.
You had to manipulate the system. In blue, and then Dr. Rouse, please, and then we move on.
Thanks. Avian Bailey again. My experience, again, from being in the hospital in a management capacity, I was also the head nurse of accident and emergency, and then eventually the manager of that department. And the long wait really cannot be helped because of the system, the way how it is set up. You find that...
So you mean it cannot be helped under the present construct?
Under the present construct.
I would be shuddered to think that it cannot be fixed.
No, well, we would hope that somehow we would come up with some sort of solution. But from my aspect, looking at it, what happens is that the exact same doctors that are on call for the day, those doctors are the ones who have patients on the ward and will now have to do ward rounds on mornings to see those patients. It is not just seeing the patients on the ward, but then they may have relatives who are coming in who need to get information on their patients. Those same doctors have clinic going on downstairs.
So while they're on rounds, they're on call in accident and emergency?
As well. And therefore, the accident and emergency doctors would have seen the patients when they came in, decided to refer them to whatever specialty, but these doctors are upstairs on the wards seeing about patients. When they finish, they probably have to eat breakfast or something like that. They also, let's just say they are surgical doctors, they may have theater that day. So now, the patients that are in accident and emergency waiting on the referral from those surgeons have to wait for after the ward rounds, after they go to theater and see whatever elective surgeries they may have had. Then they would go into accident and emergency, which may now be nighttime. Then they would see what's going on there and see if there's an emergency patient that has to be done, because most doctors, they're on call for 24 hours.
So our aim is to get some a full range of experiences.
That's right.
Have you experienced a time or periods where there is a workflow analysis done to see how efficient the systems are working with a view to making changes to make them more efficient?
NCRHA did it. It's called a throughput. They have been doing it for the last year. They started it after COVID, looking to track a patient from accident and emergency to the end. I have seen some of the reports. The reports is just tracking it. It isn't really getting it fixed because, as you said, there's so much shortages. So even though they may see where the gap is, where the problem is, they have been unable thus far to really implement any sort of change.
Would you say
it's
because the public healthcare system is the system most average citizens go through?
That's it. So there's a lot of people accessing it.
So is it a volume versus capacity issue?
Both. It is both. So we need to get that balance strike in order that we can move forward.
Thank you. Member Singh? Before we go to Member Mohit.
Thanks, Chair. Just wanted to go now to, I know we've spoken to the management and we've clinical diabetes. I just want to switch now to cancer. For persons to share their experiences regarding challenges in accessing treatment for cancer and chemotherapy, radiation therapy. Some of these some persons, in that specialty area now, from either side, from the nurses' side, from the patient side, if you all can share some experiences in regarding cancer treatment at our public health facilities.
Well, it's interesting, Member Singh, that the young lady in front here was identified earlier on, because I want to be careful with people's medical information. So I just want to repeat what you said, that you were told when you went to get remediation for symptoms that you thought you were going through menopause, that the doctor advised you that through your hysterectomy, I think you divulged that to us, that she thought that you had cancer.
Yes, what happened? Sorry.
And if there was diagnosis shared with you about that and any treatment received about that related to that?
No, she made a mistake because she just assumed that the hysterectomy was due to cancer because all my organs were fused. And she advised that I need a vulvar pap smear, but I can't pronounce the vulv smear, I believe it is. And she said, you need to do that so that your cancer would not return. So I was like, I said I didn't even bother. I just did not bother. I just said, okay, I didn't even know I had cancer. And that was the reason why they did hysterectomy.
But how do you feel as a patient that a medical care professional is giving you information that did it turn out to be inaccurate?
Yes, it was very inaccurate.
How did you feel about that, though? Because, I mean, at the end of the day, I'm not medically trained.
Right.
You're not medically trained. We go to depend on the expertise of this person to guide us in our healthcare journey. And if you are being given erroneous information, that is profound to me.
So what I do my research. I do exactly what that I've seen doctors do. I Google.
Darling.
Doctors Google.
Let me be responsible and advise you that is not the way to go. Okay? That is, I'll be irresponsible to tell you to stay with that path. People go to medical school for a reason. And while I understand you are being proactive and you are doing what you can do, what you should do is go to a medical healthcare professional to get a proper diagnosis.
I agree.
Right? So I just want to be responsible and say that because that's important because this is going to be broadcast. Because I don't want people going outside and saying, well, I can Google and diagnose myself. That would be highly irresponsible. But it's a serious issue.
I understand.
All right?
I understand. And you see, if I did not know, because I tell you, I keep copies, I keep records, and I just let her talk because I'm assuming she's tired, she's seeing a lot of
So did you
patients.
seek a second opinion?
No, I know I don't have cancer. She just misread everything in the file. Now, if I was not knowledgeable about my condition and understanding what it is I'm going through, I would have been left there in a mess. Now, I'm hoping that when I really do this test, I don't have cancer.
Well, that's what I'm hoping that you get a thorough examination by someone to ensure that you don't have cancer, because I think that's important for your healthcare prognosis, right?
Yes, because I'm not sure if this is true, so I'm going to just need some clarification, because I've been told it's not easy now as a cancer patient to get services at the St. James Health Facility. You have to go through a screening to see if it is you are financially unsuitable. Am I correct?
I don't know.
Anybody? I don't know. I'm asking because I'm hearing that.
Well, we're glad that you're saying this because the lack of information is also going to be part of our report that the public needs to be aware of what's available and what's the process to access what's available.
Yes, because I'm hearing that you have to fall below a certain bracket now to get the access to services. Because when my mother had cancer, we went to the St. James Infirmary, and obviously there was a wait period and that kind of thing, and nothing is, we understood you had to wait. So she was able to avail herself of the services provided, there. But I'm not sure now if it is that you have to fall under a certain bracket in terms of finances in order to actually access.
Well, your question will be certainly part of our report, so that information can be disseminated. Anyone else has a comment on cancer?
Once again, Edie Stewart, and I worked in St. James. I'm an oncology nurse, and you do not. The evaluation is only for if you have alternative streams of facilitating cancer care. It's quite expensive. So if you have insurance, they would depend to the insurance to assist. But no one is ever turned away for cancer treatment. Well, even before I go into the treatment and radiation, all of that, I would have witnessed on many occasions patients with early stage cancer, stage 1, stage 2, being treated inappropriately, privately by herbalists a number of persons, and then they end up within the system at stage 3 and 4. And again, because we don't have accreditation standards within Trinidad and Tobago to see what some of these private practitioners are doing and prevent persons coming to St. James, San Fernando, Eastern, or Tobago at a late stage. So it again highlights the shortcomings of our system. Just with the wait times, the 3 areas I see where there's a deficit which could be easily fixed is the role of nursing personnel within the whole NCDs dynamic. The world has long moved away from someone with diabetes, hypertension, having to sit for 4 or 5 hours to see a doctor to tell them XYZ in terms of maintaining their health. Nurse practitioners do that now, nurse specialists do that now. We have a lot of nursing personnel within the system, and they are relegated to being clerks most often than not within these healthcare facilities, moving files around when they can actually be doing what they were trained to do and advise the patients. You really have no need to be waiting so long for the majority of the concerns I'm hearing today, for the majority of them. And you only need to see the doctor when you really need to see the doctor for surgeries, what have you, or whatnot. But nurse practitioners doing all of that. There's a problem. In 2015, the Act was changed that allows nurse practitioners within our facility. However, there's no regulations to accompany the Nursing Personnel Act. So currently, no one could actually register as a nurse practitioner in Trinidad and Tobago. And despite there are a number of Trinidad and Tobago nursing personnel working abroad, wanting to come back home to deliver the service, there's not even a position on the regional health authorities called nurse practitioner.
Well, I try to stay away from the HIRS issue and deal with the experiences of patients and yourself as a nursing person. So I understand the hiring and the number of nurses issues, but we really we have a different mandate for this interface.
Okay. All right. In terms of, there's a shortage of specialists. In oncology, there is adequate oncologists. There are a number of persons trained in oncology in Trinidad in terms of the consultants, the doctors, what have you. Unlike some of the other specialties. And that can be an opportunity.
What are the specialties you suggest maybe needing more personnel, trained personnel?
Well, you're speaking about cancer, chemotherapy, or across the board, because there are a number of shortages.
You just said you seem to indicate there seem to be adequate oncologists. But there are other areas that may need some additional personnel.
So orthopedic, there's a shortage of orthopedic specialists. There's a shortage of cardiologists, a shortage of I think there's only one neonatologist in Trinidad, or 1 or 2. So, and the ironic thing is, we have an overabundance of pharmacists, you have overabundance of vets, overabundance of dentists being trained at UE, and we have a deficit in terms of specialist doctors. There are certain dynamics with training specialist doctors. For some reason, I was told by my colleagues, I said, why it's so difficult to be trained as a specialist in Trinidad? And they give me some information which would be inappropriate to share here. But that is an issue, and I think this is a committee that could really investigate why it's so difficult to be trained as a specialist in Trinidad and Tobago, and persons have to migrate to go and get this specialist training. How many persons we are actually training at UE? And again, our next aspect, those specialists that we do have in Trinidad and Tobago, as my colleagues was indicating, nothing can really happen within the secondary healthcare facility, the hospitals, without the consultant being consulted, or the registrar. The house officers could only do so much. And what often happens, the house officer could have completed what they have to do, but they need to get a final approval from the consultant. And where's the consultant? Well, the Welsh report, which looked into that, which tried to address our consultants being away from the secondary healthcare facility. And there was actually a vote within the Welsh committee. And 3 of the committee members voted one way and 2 voted the other way. But
if we could start to wrap up.
Okay, let me wrap it up.
We want to move on.
So I would really want to focus lastly. Well, let me leave it there. I have so many to say.
All right, Member Mohit.
So we now move to high blood pressure in terms of access to any particular treatment. Any challenges anyone would like to share with us? Same across the board for all 3.
So all 3, diabetes, cancer, and high blood pressure, the same issues arise in each of those special. Okay, understood. All right. All right, can we move, Member Nackett? Access to medication.
Yes.
It's the next topic.
Any challenges with the CDAP for anybody? Let's hear.
The CDAP drugs, the more low-end drugs, are not, why isn't there an availability of some of the high-end drugs for high blood pressure?
Could you explain what you mean by that, please?
Okay, so we have metformin on... Okay, so the first most common prescribed is the metformin. However, under the CDAP brand, they will get the Health 2000, they will get the APO, metformin, and some other generic form. Why can't they get glucophage or the metformin tank? How come there's not things like Genovia or Janimet on the CDAP program?
No, for clarity, for those who may not be as trained as you or in the system, what is the difference in terms of the outcomes that you can share with us?
Right, so Genovia is one of the high-end brands for diabetes treatment.
So when you say high-end, it means it's more effective? It's been proven to be more effective?
Okay. It is more effective. It is also more expensive. Right? So most times when they don't get it in the hospital, which is very rare, right? They have to buy it on the outside. I think one tablet is like about $16 for one, and sometimes they have to take twice a day for 30 days. Right? These are pensioners. And that's just one medication. Sometimes they have to get for high blood pressure, diabetes, cholesterol, right? The CDAP program, all the CDAP drugs are generic drugs. Why aren't there the availability of some of the high-end products on the CDAP program?
Well, clearly it's a cost issue because
we know it's a cost issue.
The higher-end drugs are going to cost more. The generic drugs cost less. So I guess maybe it's, and I don't know for sure, it's a policy decision to get more drugs in terms of the generic brands to be able to buy more. I don't know, but it's something we'll put in our report.
But it's one of the challenges that
experiences experienced
because of the high end.
And would you say this is across the board for all treatment types?
Yes. Yeah, because the CDAP covers most of the chronic.
Anybody else has a view on that or experience?
Yes, so it has to do with cost. In a management point of view, you would always try to cover as much persons as possible rather than a few. I would just like to suggest what the gentleman was speaking about very early, about the environment, the type of meals that are available. if it is that the government is trying to improve healthcare, we also have to look not just only at the health aspect medication-wise and hospitals, but we also have to look at the food that's available, the amount of sugar content in juices and so forth, because a Coke in Trinidad is not like a Coke in New York. Because if you taste it, you'll realize that they have much less sugar in their product. So it's, as you said, the environment itself. So if I am in healthcare and I'm trying to see that there's so many diabetics in Trinidad and there is a need for them to get medication, I'm trying to cover as much persons as possible, but sometimes the medication really isn't effective. So being in the hospital, I can tell you, you give the patient the drug and when you check, there's no change. But if they have money and somebody bring a different drug, same class of drug, you would see the differences in the outcome. So again, from the government point of view, I know that they would be looking at cost. How can I provide the whole of Trinidad with diabetes meds? They are not going to choose the most expensive medication.
Thank you. We're wrapping up on time, so if the responses can be concise, please.
Thank you. I'm going to take this from a different angle. When you do the policy will derive from you seeing a need with people being sick. Okay. So you do your research and you say, okay, we need to do this, and how you craft the policy. Coming out of the policy will be a program. And in these cases, many times it's means tested. But it's a double-edged sword that I'm realizing, because when the ministry would see the program being successful by the amount of people accessing it. Good? When CDAP came out, it was for the elderly. It started off being for the elderly. Then suddenly you heard that school children with type 2 diabetes, and then it reduced the age to 18, and then it opened up. Now, from a policy perspective, fine, people are accessing the CDAP. But when a macro perspective is asked, let us say from a PAHO and WHO, who looking at global trends and whatever, and seeing the trends in like the CARICOM region and whatnot, their measure of the success of that program would be how many people dropping off.
Well, our data that was shared with us from the Ministry of Health indicates that we're heading in the wrong direction with these non-communicable diseases. So it has to be the data points that are driving, the data points that are driving the assessments of if the program is working and how much it is working and what maybe needs to be changed. That's my logical thinking.
And then what I was told from an insurance company, a colleague there, they have a term called moral hazard, meaning you'll open an insurance company. Most of the insurance companies now have a medical policy.
I would ask you to pause right there. Stop right there and veer off that road, please.
No,
right.
This is not on the insurance companies,
Right.
This is on people's behavior.
Mm-hmm.
I know I covered, so guess what? If the black cake calling me, I could take a little chance.
Lifestyle choices.
You got it?
Yeah.
And as a result,
we're running on time.
Relatives get involved. Thank you.
Any? Sorry. Any problems with the cancer drugs? Access to cancer drugs within the CDAP?
One tablet on that.
And is it available?
It's mainly for men, and men don't really. Men.
Complete the thought, please. Men don't really what? Men don't really what?
They don't come. They don't go to the hospital. They don't get a checkup, and then those who do, it's very hard to convince them to take a tablet every day, twice a day.
So then the question that comes from that to me is how can we get men to change those habits and not just accept it as a status quo? Because, I mean, at the end of the day, it's also men form a significant part of society. And if men are not accessing healthcare when they should, and men are generally prone to a lot of diseases that women are not. So if men are not accessing healthcare for whatever reason, we have to identify the reasons and put systems in place to improve men's propensity for accessing healthcare. So I think what would be helpful is us understanding what is the dynamic behind that. I mean, there's a cultural trend with men feel they're invincible and they need to feel it tough, and going for help is not necessarily culturally relevant, but we have to identify.
Sit down in the hospital and wait. They're not, a woman would sit down and wait because she wants to get better. But a man is not, you're not going to get a man.
So it goes back to the wait time again.
Yeah. From the time a man see the line, he going back home. Yeah.
No.
He said that.
All right, we have 9 minutes left. Very quick because we're running out of time.
What I am getting the tail end of it, the impact it is having on the working adult children who have to take time off to be with their elderly relative in the waiting period. So they have to sometimes ask for a day off. And what is also happening now, they are now going into EAP because the productivity is dropping, and their panic and their anxiety and their the adult children who are not old, they're in their 30s and some of them in their 40s, and they are the ones now getting the impact of the stress that have to accompany their elderly relatives. So it's time off from the job, get the relatives, stay a whole day waiting with them, and then to take them back home before they rush back to work. So what we see now is that they're working on this to do like an epidemiological profile on that age group 20 to 49 because they're under a lot of stress. From because some of them are children, they're married and whatever, extracurricular, and now to also see the sandwich between their own children and their elderly parents. And that is the stress. Because they're juggling time.
Thank you. We have 2 sections to go through. Member Mohit and then Member Singh, and then Member Naked, you wrap up with public awareness initiatives. So we're moving to prevention now, which I think is very important. Member Mohit?
Yes, thanks, Mr. Chair. In terms of prevention, notwithstanding our first contributor mentioning change the environment to make healthy choices, the easy choices, in your opinion, do you think enough is being done by the state to educate the public on preventative measures that can be taken to reduce non-communicable diseases in your country? You can utilize the mic and... Yeah.
And again, let's be concise, please, because we're running short on time.
Well, there could be education drives, education measures, but as I said earlier on, education isn't enough. As I said, you could drill into people's heads that you're supposed to be eating this, you're supposed to be eating that, you're supposed to be eating this amount of that. But when people see food in front of them, they're going to eat what is in front of them. They're not going and think about how that food was made, how much salt was put in that food, how much sugar was put in that food, whatever, how much oil was put in that food. They're not going and think of it. All they just see is food. Food is to eat. And plenty of people will say, well, here what? I will deal with the consequences after the fact. What we need to do is that the education can just be one part. But the bigger part what it has to be the environment has to change. As in like the food we eat, that has to change. Like for example, 1 pound of pilau, according to some recipes, it could be over 1,000 milligrams of sodium in it. One serving of sararoti could be 500 milligrams of sodium. We have to change the environment.
Thank you. Another comment? Prevention?
I believe prevention is lacking in Trinidad and Tobago because regarding people who get paid, when you get paid on a Friday, you have to go home and see body check, clean the house, then cook dinner. But then KFC have a $20 special 3-piece with fries. You can't get $20 for something without oil or something healthy. You could barely get plain talk. healthy food in Trinidad is expensive. But I don't want to call name of places, but certain places with healthy food, you spend over $50, $60 with great tasting healthy food, falafel, hummus, no oil, no egg, real healthy.
A large part of it is convenience too. Fast foods are convenient. You grab it and you go.
KFC in every corner.
Leave kid. Let's.
Okay, I'm sorry.
Remember, Singh. We get the point. Fast foods. Let's not use brand names, please.
Okay, agreed.
Right?
Please forgive me, KFC, for saying that if you all hear me. I'm just saying all these fast food places are at your doorstep.
But it is what it is.
For the healthy foods, not in the environment.
Thank you.
Thank you, Mr. Chairman. I mean, the conversation today really...
Let's just pause,
sure.
Sorry. There's a hand in the back. He's not commented before, and then we go to you. Sorry about that.
Hi, good afternoon, everybody. Daniel from UNICEF here. Good afternoon to the members of the chair. I think a conversation that we need to be having in direct correlation to NCDs is about mental health. A lot of these very well-known organizations, such as the CDC, the World Health Organization, the Global Alliance for Chronic Diseases, they recognize that intricate connection between mental health illness leading to NCDs. And I think in Trinidad and Tobago, we have a huge problem in addressing mental illness in their relation to NCDs because, the doctor would have mentioned before, alcohol consumption, tobacco use, the poor diet, all these things are risk factors, even according to our own HealthGov TT, risk factors that contribute to NCDs. And I think it's a conversation that needs to be had in Trinidad and Tobago. Thanks.
Thank you. Member Singh.
Thank you, Mr. Chairman. I mean, a lot of the conversations, as we started with our sister in her contribution, I just want to close by asking the question, do we live to eat or do we eat to live? And that is something, at a personal level, you all need to discuss. In coming to the health of our country, and I'm coming to the question, the health bill in this country is $6.892 billion per year. The education bill for this country is $7.453 billion. So it's not that the government is not putting the resources there. Something else is happening. The agricultural bill, Mr. Chair, is $1.3 billion. And a lot of what we have spoken here today, Member Mohit raised it just now, the environment, healthy choice, easy choice. And from the discussions today, how easy it is to get unhealthy food. And you get paid on a Friday and whatnot, it's easy to just pass by a fast food. And just to stick a pin, Mr. Chairman, the fast food chain that members have been calling is local chicken. So I just taking that as a little pin, is local, right? It's local chicken.
It's not a chicken.
It's not a chicken. But I'm just saying, in moderation, because if you give a child the option, and I'm going to blame some of the adults here, a plate with provision and steamed fish, as opposed to the very colorful box of the fast food that you all been calling, 5 days a week, and put that in front of the child, what do you think the child will choose? Right? So it's for you, it starts at home. The education drive starts at home. And from where I sit, in terms of the health risks that we all face, coming from a family, Chairman, it's hard to tell a East Indian family stay away from roti every single day. Member Mohit knows what I'm talking about. Roti and fry aloo. So what we are lacking, Mr. Chair, is the education and the dietitians plan for us at the start. Because when you tell a East Indian, stay away from roti and fry aloo is just carbs and more carbs. No protein, nothing of the sort. But it starts at the lifestyle level from growing up. That is what you know, that is what you will continue. So education is key to being able to understand you will eat to live or live to eat. And it will end up badly. The story ends badly. And the statistics is here. Our health bill, the second largest allocation to our national budget is the health bill. And that is reflected on all the concerns that you have raised here. And we can change that with our lifestyle, but I agree. And the question now is, what do you suggest the government can do to improve its strategies for encouraging healthy lifestyle choices?
Concise responses, please. Thank you, sir.
Good night, everyone. I'm Corey Dillon from the Nursing Association. Hey, good afternoon, sorry. I just want to put forward something. The government would have signed on to multiple agreements when it comes to wellness. You have the Caribbean Charter for Health Promotion, you have the Declaration of Port of Spain, and all these things talk about what should be done. The guy in the back would have indicated the healthy choice being the easy choice. All these came out of the Caribbean Charter for Health Promotion, which was something signed on to since in the 1990s. So the question is asking, what do you suggest the government can do to improve strategies for encouraging healthy lifestyle choices? They just need to follow the charter. That's all they need to do, to be honest. The charter has been in existence for probably more than 30 years, 20-something years. So it's just to follow the guidelines on the charter. It has what needs to be done in terms of wellness policies. And it's very important to know that within our healthcare system, as the Honourable Member would have indicated, we are spending so much money on our healthcare system. There are very few persons working in the health sector who are health promotion specialists. You have persons specialized in illness care. So doctors and nurses training is primarily on illness care and rehabilitation. How many persons are exercise persons, fitness persons working in the healthcare system? Very few. Dietitians, very few. Health promotion specialists, very few. And we need to reorient how these services are done to have more persons like those employed. Because if we are in a preventative mind frame that we want to decrease NCDs, it will not occur with the current training of our premier professionals. Because I talk about nurses and doctors in particular. Those are the persons meet. And it is not, and I'm a nurse, it is not our specialty area to promote wellness. There are persons who are specialized in that. And we need to employ more persons like those.
Thank you. It's a good segue. We have to go to Member Quay wrapping up now, who is a sport and fitness specialist. So we'll end with Member Nakil.
We used to be. I'll combine this question for everyone, and it has to do a lot with the brother who at the beginning spoke about education and environment. You've seen the government implement a lot of things lately, like the wellness programs, the TT moves, something with Wednesday, Water Wednesday, and this Friday, and so on. What do you all think? Is that a day late, a dollar short?
Okay, now with regards to TT moves, as I said before, TT moves puts the focus on the individual. But if you want to address the health of a nation, we need to deal with the nation as a nation. And when you're talking about, okay, as I said, with regards to the environment that we live in, a lot of health experts in Trinidad and Tobago have said that we live in a very obesogenic environment. So the obesogenic environment has to change. And it starts with the dietary environment.
Well, hold up. Let me challenge you a little bit there, because it comes to Avinash Singh's point. We probably grew up in homes when they put something in front of us, we had to eat it.
Eat all.
Eat all. And most of the time it was healthy. I know that for sure. I didn't eat fast food until I left Trinidad for the States. And that is a fact. So is that part of the environment you're talking about?
Well, I could tell you from my perspective. When I was smaller, one of the things I used to eat quite a lot was peanut butter and jelly. And we're not talking about like the peanut butters that we have now, the peanut butters which have all the partially hydrogenated oils and things, which has been shown to be problematic for cardiology-wise, and then also eating breakfast cereals and so forth. So the thing about it is that it's not every family has something healthy on their plate. There are families in which the options are limited because of the financial options. I mean, like for example, just a couple of years ago, we reduced the tax on basic food items, and one of the basic food items was canned meats. Canned meats is red meat, which a lot of which a lot of literature has shown that it is problematic. So therefore, what we're saying is that we need to address it as a nation. Not every family has those healthy options. So we need to address the environment, because I could tell you, like how the lady was, if she didn't have access to the Coke, she would not have drank it.
So let me ask a question in closing, and I just want yes or no answers to this question from more than one person. There are jurisdictions that have gone the way of changing the laws to ensure a reduction in sugars in canned foods, canned juices, smaller sizes, labeling for calorie counts on food items, etc. Should Trinidad and Tobago, in terms of changing the environment, do you think that is a way the country should be considering?
Yes. Yes. Because I could tell you, but
yes or no answer, sir?
Yeah, sorry.
Right. Anybody else?
Yeah.
All right, well, we're going to have to leave it there. But yes, go ahead, ma'am. Sorry.
Hi, I'm Denise. The import food bill is an interesting thing, because when we go to the grocery, we're seeing cereal and Coca-Cola and all these foreign companies. We don't really have local companies that promote health, as we can see. And we're seeing that a lot of our local cooks and so forth are cooking a lot of foreign things, which we know is very unhealthy. So I think we have to look at that too, in importation of all these cereals and all these things that are not good for us and for, our, how should I put it? We as black people and brown people, there's certain foods that will, make us be more susceptible of getting, these diseases. So we have to look at that as well in terms of our culture and our body type and that kind of thing.
Just to close on that point, and I'm glad you raised it, the food import bill of a nation, right? And anywhere I go, I leave with a statement. To really get a grasp on the food import bill, at present, year on year, our food import bill raised by $1 billion. I want to just say, you impact the food import bill. When you go to the grocery, check your own fridge when you go home, check your own pantry, and you will see the food import bill staring you in your eye. And you talk about cereal, we have local manufacturers of cereal. Why choose the foreign when you could have the local? No, I know for various reasons people may choose. Simply to say, you choose the healthy option. And it starts at home, because as Member Nakid said, the environment in which you grow up, that is what you see, and that is what you will extend to.
But I would add there's a psychology to food. And if you go down an aisle with 90% foreign stuff, you are going to choose one of the foreign stuff more than likely. The issues of availability and environment, I agree with that. We would like to thank you all for being here with us today. We appreciate you being with us, all stakeholders, and you, the general public who participated. Give yourselves a round of applause. Thank you very much for this very engaging conversation. The committee members for their support, and of course the staff of the Office of the Parliament of Trinidad and Tobago for your procedural and logistical support, and of course the viewing and listening audience. This is the first of a series of town hall meetings where we are going out to the public and bringing them into our conversation about health and healthy lifestyles in Trinidad and Tobago and NCDs. On behalf of the entire team, thank you and be safe. Thank you. Yeah.